All right, PFO closure is kind of has been an up and down topic in interventional cardiology for the last probably 15 to 20 years. There was a initial excitement, we'll talk a little bit about it later, of closing these, and then some data came in that sort of shut the business down for a while, and now we're back in business. So we'll kind of go through the changes that have gone on with this device and PFO closure in patients over the last few years. What is the PFO? And if you look at PFO, you have to kind of go back to your old med school days and figure out why we had a PFO. And the foramen ovale is a short intra-atrial channel where the blood coming from the IVC, and namely from the umbilical vein and the pulmonary venous system into the right side of the heart, goes to the left side of the heart. Remember, the pulmonary circulation is not functioning when you're a fetus. So the blood doesn't need to go through your lungs. It goes right straight from the oxygenated blood from the placenta to the left side of the heart and into the systemic circulation. At birth, when you start spitting out all your amniotic fluid and your lungs start functioning, your PVR drops, your RA pressure drops, and then that flap, that's the patent, that closes the patent foramen ovale, which I'll show you some anatomy here in a second, shuts that patent foramen ovale, and in most patients, it closes. So 75% of patients actually have a completely closed patent foramen ovale shortly after birth, and there's 25 or 30% of patients that have persistent patent foramen ovale. So if you look around this room, there's 50 or 60 of us that have patent foramen ovales. Kind of scary to some extent, but it's 25 or 30%. So is it abnormal? It's not really abnormal. It's just the way humanity exists. So the embryology of this is kind of interesting because it is a little pertinent to understanding where we put the device, how it sits, and the anatomic imaging that we do while we're doing the implantation. But, oops, here, let me go back to there are two septa. The septum secundum is on the right side of the heart. The septum primum is on the left side of the heart. Ultimately, the septum secundum kind of becomes the dominant part of the septum. And the primum, which comes up from below and a little bit from the top of the atrium, eventually kind of atrophies a little bit. Then a little thin portion of it's left behind that forms the floor of the foramen ovale. The majority of the septum is formed by the septum secundum, which is sort of the right-sided part of the interatrial septum. Here's again just an illustration of the flow going across the patent foramen ovale in a normal fetal circulation to the left side of the heart and then out to systemic circulation. Here's just an illustration anatomically of what the foramen ovale looks like, or a patent foramen ovale looks like. Here you have your little left-sided thin septum primum. That's the flora, the fossa. I'll show you in a second. And then this thicker part of the atrial septum is the septum secundum. So the embryologic septum secundum is the big, thick part of the septum we see on echo. That little thin